Hi, hello friends. Hi, hi. Welcome to the live, friends. Hi, doctor. Hi,
Hi,
Dr.
how are you?
Patty.
Nice to
Yeah,
see you.
all good. How are you?
Great, great. How are you?
Nice. All okay. So, first of all, I should thank you for giving me the opportunity. I'm very much delighted.
Pleasure to be here. Be
Yeah,
with you live. Pretty cool.
yeah. Thank you. So, shall we start, sir?
Yeah, let's do it.
Yeah. So the main intention of doing this Insta Live is to give some general insights for the common public who is suffering the shoulder injuries while playing badminton or tennis.
Okay.
So yeah, as you are a dedicated shoulder surgeon, so you see day in and day out all the regular shoulder trauma and all.
Right.
So how do you treat a patient who is playing badminton and suddenly he developed pain? Obviously, there is no dislocation, but he has got pain. So he comes to you. So how are you going to uh, deal with the patient?
Yeah, so I mean for me it would be more tennis, in our country. I don't see a lot of badminton in the US, especially on the West Coast where I live. But most of those patients, if you look at the data, are going to get better with conservative treatment. So we always want to start conservatively, really get an assessment if it's an acute trauma or if it's something that's been more repetitive over time to start. And I think in those patients, like I said, most of them get better with conservative treatment, but it's also important to make sure that you're really getting a full exam, looking at the scapula. Sometimes you'll see some injuries that'll be missed, like long thoracic nerve injury from repetitive overhead use, etc. So I think that's important to look at the entire shoulder in those patients.
Okay. So you give analgesics and advise them to ice packs and rest, isn't it?
Yeah, of
Is
course.
the
Standard, rice sort of thing, rest, ice, anti-inflammatory,
compression?
the way to start for sure. Yeah.
So, for example, if the patient doesn't have any relief even after 1 month or 2 months, so he comes back to you again with the same problem, how are you going to uh, deal with the patient?
Well, it really depends. I mean, if somebody's really, you got to really get into their history and make sure that they, make sure get an assessment of how severe it is, and then, if it's really limiting them in their sport, I think it's important for them to have a period of rest because a lot of times these athletes will not want to take rest. They want to just keep pushing through. So
Exactly.
yeah, so you got to make sure you really have clarified that they've done that. But then once, if they have truly taken a period of rest, gone through therapy, and not gotten better, that is when I will go to an MRI next, assuming I've ruled out other pathology. But generally, that's not usually at a month or two. Usually for me, that's a minimum of 3 months before I'm going to an MRI. Because again, most of them are going to get better with time, and most of this is responds to conservative treatment.
Yeah, but it's quite difficult to explain with for the patients who are highly educated in our country because they just Google everything in the Google and suddenly they find some subacromial impingement and all. They'll come, sir. I want an MRI scan. They come with their own scan. I don't know what is the process in US, but in India, getting a scan on themselves is very easy. Like within 1 or 2 days, they can get by themselves. And see, for example, if they come with the MRI film and scans, for example, it shows some partial supraspinatus tear. So, and the patient has been complaining pain from last 5 months or 6 months. Then how do you go about it?
Yeah, it's important. I mean, with depending on their age, as you know, many of these people will have partial tears just based on their age, and especially if they have a long history of doing a lot of repetitive overhead activity, then they're going to have a high incidence of having partial rotator cuff tears. I mean, in the U.S., we always talk about baseball players and how so many of them have pathology on their MRIs, but they're functioning at a really high level. So, again, I think it's just important to really correlate that. But I agree with you; it's a tough problem where, people hear tear and they think that's something that needs to be fixed, and many times it's something where there's just low-grade tearing within the rotator cuff tendon itself that's degenerative tearing over time and doesn't necessarily need treatment. So, it's just like you said, it's always a battle. But the key for me, is really if somebody's, you try to be as conservative as you can initially, and then if you get to that point and you can correlate the exam with the MRI and the patient is really limited, then if they fail conservative treatment, then I'll consider something surgical at about the 6-month point.
Okay. So if the patient is a tennis player, he has got a partial tear, and which is affecting his daily routine activities. So how do you go about it? Like you do arthroscopy, or you still try to treat it conservatively?
Well, for me, I would want that patient to fail therapy and injection, and then if they fail
Okay.
that, then I will consider a scope.
Okay. So how routinely in US the injections were given into shoulder and knee?
Pretty
In India, we
frequently.
have so sorry to interrupt. In India, we have two schools of thoughts. Like one group of surgeons, they strictly no to give injections. Like they tell that it is going to damage the joint, especially if the patient is diabetic. And the other group of patients, like for every patient, there will be a lot of other factors. Like for simple ONE, they cannot straight away. We cannot tell them to go for a knee replacement. Even if
Right.
for example, if the patient has got glenohumeral arthritis, we can't tell them straight away go to shoulder replacement. So some group of surgeons we give injections, some group they don't give. So how is in US?
I think it's still pretty common in general in the U.S. to give injections. It's certainly gotten to be a lot more conservative because of the data that showed primarily the risk of infection after if you have a joint replacement or scope after injection, particularly within 3 months. So, when I trained, I learned, generally speaking, the maximum of 3 injections in a 2-year period. That was just kind of a guideline that was used. But for me now, it really depends. If it's somebody who is very low demand and we are really trying to avoid surgery, they're typically older, I will still do, 3 injections in a 2-year period. But if we think there's a high chance they're going to go on to a rotator cuff repair or shoulder replacement, then I try to only do 1 injection. And then if they fail that, then we're talking about something surgical. And if it's that patient who's younger, say you have a 40-year-old with a rotator cuff tear, that's a full thickness rotator cuff tear, I don't think there's any place for an injection in a full thickness rotator cuff tear.
Exactly.
Generally, I would say if it's full thickness rotator cuff tear under the age of 60, which to me is a high probability of fixing, I don't think there's a place for injection. I'll use it for rotator cuffs in that younger patient. I'll use it for a partial tear.
Okay. So what is your criteria for doing surgery for partial tear?
Well, generally speaking, I want to look for a high-grade partial tear that's failed conservative treatment, which was what we talked about, injection therapy for a minimum of 6 months, sometimes as early as 4 months. If they have lower grade changes, though, and they failed conservative treatment, and I'm really convinced on their exam that they indeed have shoulder pathology, then I will offer those patients a scope as well, because sometimes you will find that the tear is more extensive than you saw on the MRI. So I think it's like any of these tools we use, they're not perfect, right? So an MRI isn't definitive in every case. And so you put it together as best you can and try to help people who you feel are still having problems after conservative care.
Okay. So how routinely you do subacromial decompression in a patient suffering with subacromial impingement?
Isolated subacromial decompression is an uncommon procedure for me. I think that
Okay.
should be an uncommon procedure, as an isolated procedure for you. For me, that's less than 5% of my practice. There are some of these younger patients who I do think indeed have impingement from repetitive overhead activity, but I think it should be very rare that you see that in an older patient, say somebody over the age of 45 or 50. So now, as part of a rotator cuff repair, I still routinely do subacromial decompression. And for me, that's a limited acromioplasty. I don't take down all of the CA ligament, but I'll do a limited bevel, and I'll specifically focus on the lateral aspect based on the
Okay.
data regarding acromial critical shoulder angles. So.
Okay. Nice, nice. So while doing cuff repair, you convert the partial cuff tear into a complete cuff tear, and based on the type of the tear and extent of the tear, you do either single row or a double row, isn't it?
It's really, that's a matter of philosophy, right? You're either a takedown or you're a fix in situ, right? And I'm a big believer in preserving anatomy. So if there is a rotator cuff tear, it's a high-grade partial tear or partial articular sided, 90% of the time, I'm going to preserve that and go trans tendon rather than do a takedown. I will only do a takedown if it basically goes 90% through and I essentially have almost a full thickness rotator cuff tear. So that's a matter of philosophy. I think really the data doesn't prove that one is better than the other, but I just believe in restoring the anatomy.
Okay, nice, nice. So coming to the another aspect, which is very common in diabetics and thyroid hypothyroidism patients, what we regularly call in India is frozen shoulder or periarthritis shoulder or adhesive capsulitis. So what's your line of management? Like if the patient has got pain in the shoulder, diabetic patient from last 2 months, 3 months. So when do you advise surgery
Yeah.
and when do you do injection?
I always start conservative in those patients. Most of them get better. The key is trying to pick up the diagnosis early. To me, it's surprising that you still see frozen shoulder missed a lot, even by orthopedic surgeons, especially if it's not, obvious. If it's not somebody who's, stuck at 90 degrees, maybe they have 20 or 30 degrees loss range of motion. Particularly, many of those patients will have loss of horizontal abduction, so they can't get back to the throwing position. That, I think, is probably the most sensitive test to evaluate for frozen shoulder. But I will start with injection in those patients in a dedicated stretching program that we give to them, and we have them just follow our videos. Even if they're diabetic, I will typically still do the injection. And I will just let them know that it's going to raise their blood sugar levels temporarily and they need to keep a close eye on it. If those patients have gone through 6 months of symptoms and they've failed conservative treatment, then I'll start talking to them about a release as an option. If they're diabetic, though, I won't do that if their HA1C is above 8. Some people will even have a lower guideline of 7, but my cutoff is generally 8. And then there's the converse is, well, what happens if you just wait? And some people don't want to do anything, and that's fine. But I'll tell them if they start to get beyond a year, I do worry about them not getting the same improvement in their range of motion long term. And there's some data that we have now that shows, for instance, that patients who had symptoms over 9 months had later on that they didn't get as much internal rotation back if they had conservative treatment versus if they had a capsular release. So my cutoff's right around there for really trying to recommend surgery.
Yeah. Yeah, one more thing. In your clinical practice, how do you diagnose, how do you differentiate between cuff tear and periarthritis shoulder? For example, if your fellow asks, sir, how do you diagnose? Like based on clinical examination or an MRI finding?
Distinguishing rotator cuff tear from what?
Periarthritis shoulder or frozen shoulder.
Oh, frozen shoulder. Yeah. So if they are stiff, you know, I will always start with the conservative and try to go first, you know, but it depends. If they're dramatically stiff, like say they're at 110 degrees or less, that's almost always frozen shoulder. It's that in-between patient, right, that maybe has 10 to 30 degrees of loss of motion. And so what I will do is I'll try an injection first, but I won't keep injecting them over and over. If they come back a month later and they're still having symptoms, then I get an MRI in those patients. Because what you're getting at is that some of the patients with rotator cuff tears can have a mild degree of stiffness.
Okay. No, what I want to ask is, like in the OP practice, in the OP, how do you differentiate between periarthritis shoulder and a cuff tear?
Between
the tests?
Between frozen shoulder and rotator cuff tear.
Yeah.
Yes? Yeah. So
yeah.
Again, I'll start with injection first, and if they don't get better after a month in those patients, and I'm not sure, then I'll get an MRI to really determine if they have a rotator cuff tear as well.
Okay. In India, what we were taught traditionally is like, in case of periarthritis shoulder or frozen shoulder, both the internal and external rotation movements are decreased. Whereas in case of cuff tears, actively the patient can't do, whereas passively we can do the movements. That's what we were taught. What's your opinion on that?
Well, yeah. So I think that the issue though is that you'll have some patients with a rotator cuff tear who have frozen shoulder as well, right? So they have stiffness, they have passive and active range of motion loss, and they have a rotator cuff tear. So that's the patient I'm talking about. Clearly, if they have just active range of motion loss, but you have full passive, then you're thinking more, okay, this is pain related. But I'm talking about the patient who has active and passive range of motion loss, and I thought you were asking, how do you know if they have a rotator cuff tear, which you will see occasionally.
Okay. So how commonly in your practice you operate on frozen shoulder?
Oh, I mean, fairly frequently, actually. The majority of it, we treat conservatively, but we see so many patients in our clinic that I'll probably do a release for frozen shoulder once every 2 weeks, I would say. So a couple of times a month. But, I'm really seeing those patients after they've been screened by my team and been, all the people who have had conservative treatment don't get to me.
Okay. So you after the cuff release, capsular release, you again put them on a physio program?
Yeah, exactly. I think it's important that those patients right away start range of motion. I will have them start the day after the procedure, and then do 3 times a week for 3 weeks. And then I think they can traditionally or generally transition into a home program after that. It's really just getting to it at the immediate phase.
So in US, is anyone following the manipulation under anesthesia method? Nowadays I think no one is doing that.
There are still people who do manipulation under anesthesia. I still see that from people in my surrounding area and throughout the state where I live. And I'll see these people get sent for, a release because they failed the manipulation. Interestingly, there's a few insurance companies at least around me, that will not allow a manipulation to be done because of the risk of complications. So a few times the insurance company has sent me the patient because I'll do a release. So yeah, but it still exists. There's still people who that's how they go about it.
Okay. So what's your opinion on hydrodilation, the shoulder?
I don't have experience. I mean, I've seen the data. Um, you know, our success rate is so high with just a general injection of 10 cc's that I have not done that in clinic. Have you had experience with it?
Yeah, we do it regularly
Yeah, yeah.
because
And
it gives.
how do the patients tolerate it?
Yeah, what we do is we give 1 to 2 cc of depomedrol, then 1 to 2 cc of lignocaine, that is a local anesthesia, local anesthetic drug, then around approximately 10 to 15 ml of normal saline or distilled water. So basically, the idea is to distend the shoulder joint.
Right.
So some surgeons do under anesthesia, under C-arm. So I have very little experience on hydrodilation, but not more than one case a month. I regularly give intra-articular steroid injections under ultrasound guidance.
Right. That's what I
Uh,
do. I use ultrasound guidance to make sure I'm in the joint. But
in the
I
last
think,
2 months, I think I have given for around 20 patients under ultrasound guidance.
yeah.
Because as you are aware, nowadays the trend is we are moving towards ultrasound guided injections.
Right. Yeah, I do all my injections with ultrasound as well. And I think the data shows, you have improved accuracy, but I also think the patients appreciate ultrasound better because it gives them confidence, and when it sounds simple, but when you put your hands on the patient and they feel, that you're in the right spot, that I think is better as well. So.
Yeah. So, sir, did you see any cases of capsular release, arthroscopically done capsular release patients again coming back to you with the same problem?
Very rarely. I only have a couple of those in my practice over the last 11 years. And I've had a few that I just can't figure out. Some of those are, some of those are obvious, like somebody who has very brittle diabetes, who you just cannot get under control. I think another thing you have to think about in those patients is perhaps infection that's being missed, because we know that C. acnes can cause stiffness of the shoulder. And then, I think if you get to somebody very, very late, you can have somebody who remains persistently stiff despite your release. I try to, if I get to those patients late, like say they come in 2 or 3 years later, I'll try to counsel them that their prognosis is lower. But the vast majority of patients with a release are going to get very, very good result.
Okay. So while arthroscopically, what are the structures you focus, like what are the structures you release in capsular release?
Yeah, so this is an interesting topic. I just do a release of the rotator interval, the coracohumeral ligament, and then I'll release the anterior capsule as far inferior as I can see with a 70-degree scope. And then from
Acha, you
there,
use a 70-degree scope.
yes, yeah, I'll start with a 30-degree scope. I'll open the rotator interval, and I will release the anterior capsule, and then I will go to the 70 to make sure I release the coracohumeral ligament up superiorly, and then down as far as I can for the inferior capsule, releasing through the anterior portal. And then from there, I will just do the manipulation. Okay, I don't
Okay.
go and do a posterior release. The reason is because there's a study, I think it's out of Australia or Asia, that says that's effective. I got intrigued by that study, and I started looking at my patients, and I would do what I just described to you first, and then I would see what their motion was, and I found that they almost all got their range of motion with just that alone. Now, if I go and do that and I test their motion and they don't have internal rotation for some reason, then I'll go back and I'll put the scope back in and do the posterior release. But I really find that that's very uncommon. The patient where you sometimes see it is a very brittle diabetic, but it's not common that I have to actually go back there and change the scope and release. And then I will go subacromial and just do a bursectomy. I don't do an acromioplasty, but I'll inspect the subacromial space. And if they have bursitis in that area, I'll do a bursectomy in that area.
Oh, nice.
How about you? Do you do a 360 release?
No. Mainly the rotator interval release and coracohumeral ligament release. And as you said, we check the movements intraoperatively.
Yeah.
So if we find it is satisfactory, yeah, then as you said, very important, we do bursoscopy, we do subacromial decompression, acromioplasty if we find that if it is impinging or if it is too prominent, especially the anterolateral part with the burr, with the undersurface, we debride with the burr.
I don't like doing an acromioplasty in those patients, so I used to, but I find that if I do an acromioplasty, I felt like a few of those would have a little bit more trouble getting the range of motion back, because I think you maybe cause a little bit of bleeding and perhaps some adhesions to reform. So I only will do a bursectomy in those patients, for me personally.
Okay. Oh, nice. So, a few more, just few more things to this thing. How frequently you see the patients with shoulder dislocations, and how frequently you operate? So, what's your take?
Yeah, I mean, in younger patients, say less than 30, I mean, the two most common things that I treat surgically are shoulder dislocation and clavicle fractures, right? So shoulder dislocations, I mean, are common in that population, relatively speaking. For me, I think the data shows that if you have a single anterior shoulder dislocation under the age of even 35, there's data that says that you have improved stability or lower rate of redislocation with an arthroscopic labral repair. And so I generally, though, you know, my threshold is generally 30 years of age, because when you look at it, you know, the higher risk, it's obvious that the younger patients are more at risk, and that risk declines as they get older. So I don't use 35 as a cutoff, but 35 is a number that's been out there. So my general cutoff is 30, and if they have a single proven anterior shoulder dislocation, then I will recommend a primary arthroscopic treatment. And then it's Bankart or Bankart with remplissage, depending on their bony lesions and their activity level. If they're over 30, I always try to be conservative first, though.
So how do you go about a patient who has got 15 episodes, 20 episodes, both the shoulders with the generalized ligamentous laxity?
So if they have you're saying they have atraumatic instability, like multi-directional instability. Those patients, I always try to be conservative first.
So you refer to your friend.
Say that, yeah. If they have MDI or multi-directional instability, generalized laxity, I'll always try to be conservative first, unless they had a traumatic event and they have a traumatic labral tear on top of multi-directional instability. So I think it's important just to listen to those people to really try to sort out. But if they've gone through conservative care and failed that for 6 months, and I'm sure if they've done it, then I will do a capsular shift anterior and posterior and try to rebalance. Okay. But that's an uncommon patient for me. I mean, for me in my practice, you know, I'll do 30 Bankart repairs to one multi-directional instability patient. Okay. So you said you will do capsular tightening for both anterior and posterior. If they're multi-directional instability, I'll tighten the front and the back. But again, that patient to me is rare. Like I said, it's 30 to 1. I'll do a traumatic to somebody who has atraumatic multi-directional instability. I really try to be hands off in those patients unless they're just not getting better with everything.
Okay. Nice. So, coming to the Bankarts, There are multiple studies, like some they tell you need to put at least 3 anchors.
Hmm.
Some they tell at least you need to put 4 anchors. So what's your take on that?
I think, you know, it's really not about the number of anchors as much as if you've put in 3 anchors, it shows you've gotten low enough. So to me, I think it's very important to view from an anterior supralateral portal, and that's best done in a lateral decubitus position. You know, the data that has looked at that shows that those patients have a lower risk of recurrence. So the key is to see all the way to the bottom of the glenoid. And then the second thing from there is I like to really make sure I get a shift up of the capsule. And again, I think that's best done if you're seeing from the top looking down on the glenoid. So, you know, I always use 3 anchors, but it's to me, it's more about getting the view and shifting the capsule up in those patients.
So the mainly the inferior capsular shift and getting the bumper effect.
Yeah, I think the shift is the most important aspect. So, you know, people talk about a 6 o'clock anchor. You know, my anchor usually will go in at 5 o'clock, but I'm sure where 5 o'clock is because I'm looking down. But then my pass with my lasso, my soft tissue pass is below that, so I'm bringing the capsule up to that anchor.
So this is what exactly we do. We try to place our anchor between 5 and 5:30, and
Hmm.
we take the suture passer or bird beak the
Yes,
6 o'clock and take a good bite.
right,
Uh, right.
right.
So in India, we avoid placing metal anchors in the glenoid. So what's your opinion on that? Like in US, you use metal anchors or peak anchors or all suture anchors?
Yeah, I used all suture anchors. I've never used metal anchors.
Yeah.
The biggest transition for me in my practice is when I started, we were using 3.5 millimeter anchors. We were using push lock anchors or biocomposite. And now I use 1.8 millimeter knotless all suture anchors. So I use a fiber tack, knotless fiber tack anchor. Um, and that's nice just because you can get smaller holes in the bone, and you can place those through curved guides so you can get a better angle of approach. So that's been a big change for me. The one thing with an knotless fiber tack though is you have a single loaded anchor, so you potentially lose points of fixation if you just do a simple pass. So I really like to do a mattress configuration with those. So even though it's a single load, you can pass it up and back down with a knotless mechanism to get a mattress configuration, which will increase your resistance to pull through the tissue.
So you don't use double loaded all suture. We use double loaded all suture.
No, because I go mine are knotless. So
Knotless.
the knotless anchor has one repair limb and then it has a shuttling limb. So I can pass the repair limb and the shuttling limb. So my suture will go up and back down. I can get a mattress configuration with a single loaded anchor.
So what's your opinion on metal anchors? Why do you avoid? Is it because of
Yeah,
the
I think you should avoid metal anchors. A, they're too large for the glenoid. You're going to get risk of fracture. And B, I think if you have some sort of anchor issue in the joint, I think that's a bad problem. You know, the other
and
thing
revision
too.
becomes much difficult.
Yeah, what's
And the
that?
revision becomes much difficult.
It's much more difficult, but then also many of these patients, if they dislocate their shoulder, they're increased risk for arthritis. So you have to be thinking about what happens in 20 or 30 years. You go and do your shoulder replacement, it's going to be easier to do that if you don't have metal in the glenoid.
Nice, nice. So what about the anchors which you use in the cuff? What do you prefer, metal anchors or peak anchors?
Yeah, and I don't use metal. I like to use all suture anchors medially for my medial row when I'm doing a double row repair, because you get smaller tunnels and so you get less footprint violation. You know, tendon heals to bone, right? So I want to maximize the bone. And then laterally, I'll use knotless anchors. And I don't think it matters if you use biocomposite or PEEK. Of quite honestly, I like Peak a lot because, you know, they're very inert on the MRI. They don't throw off any signal. And they, you know, I don't see any issue with them breaking down. So that's why I typically will use Peak laterally.
So, but what we do is in osteoporotic bone, we try to use metal anchors. So, what's your opinion on that? It's osteoporotic bone.
Yeah, I mean, I think it's a lot of people will ask me about soft anchor, all suture anchors in older patients. And honestly, I mean, my go-to is to use it in all my patients. I find that they very rarely come out. Actually, those anchors, despite being smaller, they hold really well especially if you're not decorticating the bone, which I don't do. And I'm talking about medially. You know, most of the time you're coming in just below the head, so you have pretty good bone there. So I don't see those patients have an issue. So I don't think it's metal versus other materials. But then laterally is really your issue in osteoporotic bone, because once you go past that cortex, you know, you fall into an abyss sometimes. So there, my key is to try to, you know, I'll use a knotless anchor for my lateral row, but I try to do a few things to maximize my fixation. One is I'll try to under punch, and I'll use, instead of using 4-7-5 anchors, I'll typically use 5-5 anchors laterally. Another thing that you can do is have more sutures, because with the anchor I use, the fixation is between the anchor and the bone. So more sutures increase your resistance to pull out. And then finally, occasionally, if I run into it, I can add an additional anchor, like a buddy anchor.
Nice, nice. Quite interesting. Actually, we use metal anchors for the humerus, but glenoid never.
So you use it for medially for your medial row anchor?
Yeah, medial we can use,
Yeah.
but as you said, mainly in the osteoporotic bones,
Yeah.
because we
Yeah.
get
I
pull-out strength is better.
Yeah, I just don't find it's necessary, and I don't like them because they're typically larger, and I don't want to violate, you know, as much bone. I mean, if you think about it, if you take 2-5-5 anchors, you got 11 millimeters that are taken up, right? And if your footprint is 2x2, you took up half the footprint medially. If you have 2-2-6 anchors, now you're only taking 25% of the footprint. So that's why I like the soft anchors.
Oh, nice, nice. So, do you do all your cuff repairs arthroscopically, or you do mini open as well?
No, 100% arthroscopic. Yeah, yeah. I don't find any need to do anything open. Yeah, for my cuff repairs. That's just how I was trained, and honestly, I don't think I could do as good of a job with a mini open approach. So
Okay.
yeah,
So, uh, we uh, we had a very great discussion, sir. I am
great.
very, very overwhelmed because it will be a very great source of information for all the graduates. I mean, who are in the orthopedic residency. I think they are directly learning from the master.
Yeah.
So
Well,
you told
it was a pleasure.
you told lots of information. I think approximately more than half an hour.
Great.
So. So, for the fellows who want to reach out to you, how do they apply?
Well, for us, it's not possible to do a clinical fellowship coming from India. So it's really, you know, the opportunity is a research fellow. And we have several people at a time who do that. And we have many people who inquire about it, but they just have to reach out to me by emailing. And my information's on the ASCS website. They can email about the fellowship there. And so we take applications, but we're typically, booked out 6 months to a year in advance. So it's hard because a lot of people are interested, but it's hard to accommodate everybody. But that's the best method.
Okay, what's the duration of the program? Is
Well, if
6 months or 1
it's a research fellowship or observational, that's really at the discretion of the person and where we're at and other fellows that we have. So I think to really get something out of it, I mean, you got to do 3 months minimum, but it's 3 months to a year. But the thing about that fellowship is that's not funded. So it's something where somebody's got to come on their own expense. You know, really only the clinical fellowship is funded, but that requires a U.S. medical license. So
for graduates from India, they can come for just a normal fellowship for 3 months.
yeah, they can come for a research or observational fellowship for 3 months to a year. Yep.
Hope this video is very helpful to all the people. I have got a YouTube channel where more than 50,000 subscribers are there. I think it will be definitely useful for all the people and the general public as well. Once again, I'm very thankful. With all the warm regards, I think I'm very, what else I can tell, because you have given your valuable time and valuable the US surgeon's point of view. Because recently I got a patient, native of Hyderabad and settled in US. He has been a software engineer. He has been there from last 10 years. I'm sorry, 5 to 6 years. So he has got some knee injury. He wants an MRI. He consulted a general doctor, then an orthopedic surgeon. Then it's been, I think, 2 to 3 months. He waited for MRI scan. So we do get this thing. I think if you know you, that time I could have referred the patient to you.
Nice. My pleasure.
So,
that's what's one of the things that's fun about this is sharing ideas, you know, all over the world. So thanks for having
exactly,
me.
sir.
You take care.
Thank you. Yeah,
All right.
thank you.
Bye.
Bye. Bye.